Okay, let's talk about restless leg syndrome. You see this at the pharmacy counter all the time, right? But it can be a really tricky condition to counsel on. So, in this explainer, we're going to break down exactly what you need to know to guide your patients with confidence.
So imagine a patient comes up to you and they're trying to describe this feeling. They're using these really vivid words like creepy crawly, itching in my bones, or like an electric current is running through their legs. These aren't just vague complaints. This is the classic language of RLS, and it's a condition that can absolutely wreck someone's sleep and their quality of life. Really getting what that feels like is step one to great counseling.
So when you hear those key descriptions, what's your game plan? What do you do next? Well, that's what this is all about. This is your practical guide, giving you a clear, structured approach for that very next conversation you have at the counter.
Here's how we're going to break it down. First, we'll get a solid understanding of RLS. Then, we'll talk about diagnosis and how to investigate triggers, especially medications. From there, we'll jump into treatment choices, handle some complex cases, and we'll finish with a super practical checklist you can use every day.
All right, first up, let's really understand what we're dealing with. RLS, also known as Willis-Ekbom disease, is all about that overwhelming, irresistible urge to move your legs, and it almost always happens when you're trying to rest.
And you might be surprised how common this is. We're talking 5 to 15% of the general population. That is a huge number. It's also more common in women, and it definitely pops up more as people get older, which means, yeah, you are absolutely seeing these patients on a regular basis.
Now, it's important to know that RLS isn't just one thing. There's primary RLS, which is often genetic, but where you can make a huge impact is with secondary RLS. This is where we start connecting the dots to other issues like iron deficiency, pregnancy, or chronic conditions like diabetes and end-stage renal disease.
So how do we know it's really RLS? Now, obviously, you're not the one making the official diagnosis, but knowing these 5 essential criteria will help you ask all the right questions and figure out when to tell a patient, hey, you should really see your doctor about this.
Here they are. Think of this as your quick mental checklist. Number 1, that urge to move the legs. 2, it gets worse when they're resting. 3, moving around actually makes it better. 4, it's always worse in the evening or at night. And 5, it can't be explained by something else, like simple leg cramps. If a patient is ticking all 5 of these boxes, chances are very high it's RLS.
Okay, now for one of the most important parts of your role, playing detective. This is all about investigating the causes and triggers that could be making a patient's RLS flare up.
And the first major red flag you should always think of is iron. Get this, a staggering 25 to 30% of people with RLS are iron deficient. So, a crucial counseling point is to encourage patients to get their levels checked. Specifically, a serum ferritin level below 75 micrograms per liter is a massive clue that iron supplementation could be a total game changer for them.
And here's where your expertise really shines, the medication review. This is our bread and butter, right? Some of the biggest culprits are those first-generation antihistamines like diphenhydramine and any of the dopamine-blocking antiemetics. And with antidepressants, while SSRIs and mirtazapine can be a problem, it's good to remember that bupropion is often a great alternative because of its effect on dopamine.
So once you've done your detective work and identified potential triggers, it's time to guide patients on their treatment choices. And we always want to start by balancing those non-drug strategies with actual pharmacotherapy.
The right path really depends on how severe the symptoms are. For everyone, especially in milder cases, non-drug options are the foundation. Medication is usually reserved for those moderate to severe symptoms, and it's our job to help patients navigate the options and, of course, the risks.
So, what can patients do right away, tonight even? Advise them to cut back on caffeine, alcohol, and nicotine. Suggest simple things like hot baths, massage, or some gentle stretching. Oh, and here's a really interesting tip. Suggest they do mentally stimulating things like crossword puzzles or other games during those periods of rest. It can actually distract the brain. And for some, pneumatic compression devices can provide a lot of relief.
Okay, when medication is necessary for chronic RLS, our counseling is absolutely paramount. For dopamine agonists, you have to screen for compulsive behaviors like gambling or hypersexuality at every single visit. It's that important. For the GABA derivatives like gabapentin or pregabalin, the big things to watch for are drowsiness and unsteadiness, especially in your older patients. And here's the critical point for levodopa. It's for intermittent use only. Why? Because the risk of rebound and augmentation is just too high for daily use.
All right, let's wade into some of the more complex scenarios you're definitely going to face, and we have to start with this concept of augmentation.
Augmentation is one of the biggest challenges in long-term treatment. It's this completely paradoxical reaction where the dopamine therapy actually starts making the symptoms worse. They start happening earlier in the day, they feel more intense, and they can even spread to the arms. Being able to spot this is absolutely critical.
Pregnancy is another really special case. RLS is incredibly common here, but the good news is it usually goes away after the baby is born. So first line is always non-pharmacologic strategies and checking those iron levels. If medication becomes absolutely necessary, levodopa/carbidopa might be an option, but only after the first trimester. And then during lactation, if something is needed, gabapentin may be a more appropriate choice.
Okay, let's pull all of this together. We're going to wrap up with a final, actionable checklist to make sure your counseling is always comprehensive and effective.
Here it is, your go-to guide. 1. Always start with lifestyle. 2. Always review their meds for triggers. 3. If you do start drugs, remember the mantra: start low, titrate slow, and dose it 1 to 2 hours before bed. 4. With dopamine agonists, screen for those compulsive behaviors every single time. 5. Explain to patients that therapies might need to be rotated down the road to manage augmentation. And finally, empower your patients by pointing them to great resources like the RLS Foundation.
Ultimately, this is what it's all about, isn't it? Every piece of advice, every med review, every single counseling point is aimed at this one clear goal: helping your patients feel better, sleep better, and avoid the serious pitfalls of long-term therapy. Your role in making that happen is just indispensable.
So, as you finish up your shift, I want you to think about this. Who came to your counter this week complaining about trouble sleeping or some weird feeling in their legs? Which one of your patients could benefit from you starting this exact conversation tomorrow?